Started. Welcome all. Thanks for joining us. I know if people are still joining. Good afternoon and welcome to the Oregon Bioethics and Humanities Colloquium's presentation. Today's topic, Think in Systems, Act in Relationships, Building Relational Systems with Healthcare and Communities. My name's Cliff Coleman. I'm here with the OHSU Center for Ethics in Healthcare, and I co-chair this series along with Dave Hoyt, who's also with us here today. Our talk today continues our 2025-2026 Oregon Bioethics and Humanities Colloquium, or OBHC. Now, OBHC is a 7-part endowed speaker series that tackles complex issues and critical questions in bioethics and the medical humanities. I'm really delighted to introduce our speaker today. Dr. Brian Park is a good friend, a colleague, someone I've learned a lot from, and consider a mentor. And I'm really delighted that he's here today. Dr. Park is an associate professor in the OHSU Department of Family Medicine, where he serves as the medical director of OHSU Health Equity and is the founding director of the Relate Lab, which I think he's going to tell us about. Dr. Park's work focuses on transforming healthcare systems to not only be not only technically excellent, but also relationship centered by connecting clinician experience, community leadership, and policy change. Through this work, he's helped advance both statewide policy and innovative models in care driven by community voices. His work in relational leadership and community organizing has spread to other health systems nationally. And this has been quite a model program that we are all very proud of, knowing about him and knowing his work. So please join me in warmly welcoming Dr. Brian Park. Brian, I'll hand it to you and let you share your screen if you'd like, and I'll mute myself here.
Wonderful. Thank you so much, Dr. Coleman. Really appreciate it. And hello, everyone. Thank you so much for having me today. And really deeply thank you to the Center for Ethics in Healthcare for creating this kind of space through the Oregon Bioethics and Humanities Colloquium. For me, it feels like a space where we can just slow down from the hustle and bustle of our lives and ask not only what healthcare does, but also what it means and what all of that might reveal about our values and our relationships and our institutions and our responsibilities to one another. So before we dive in, though, let me just share a little bit about myself. My name is Brian Park. I get to be a family medicine doctor at the OHSU Richmond Clinic with Dr. Coleman. It's a community health center in Southeast Portland. I absolutely love working there. And I also do a couple of weeks of inpatient medicine a year as well. Now, that's what my very Korean parents tell their very Korean friends at the dinner table about what I do for work. And it's only really part of the truth. So I want to tell you about the other parts of the truth of what I get to do, which I've really more lately come to describe as being almost like a hospice nurse, not for patients, mind you, but for almost like the healthcare system itself. Because I think many of us in this virtual room can agree that the US healthcare system right now, it doesn't work for a lot of people. So I'm really passionate through my roles in OHSU Health Equity and the Relate Lab to really allow the decaying parts of the system atrophy and wither away, but to also still have the courage to imagine, how do we build something that's more humanizing and community centering in its place? So that's the who. Now what? What am I going to talk about? For the next 50 minutes or so, I just want to share with you all about the work we do at the Relate Lab to help people in healthcare to think in systems, but act in relationships, and how we do that through building relational systems, both with those who work in healthcare, like many of us in this room, and the communities that receive care from healthcare systems. But before we get to all that, one of the foundational skills that we practice in the work that I do is grounding into our why. Not jumping straight into focusing on the what, jumping into the agenda, what are we going to do, but also on the why we do it. Because this can be a little bit of a dead angle for us in healthcare. So I think it's only fair that I share my why. So let me start with sharing a story. Because I'll be honest, I never thought building communities is what I'd be doing as my job when I applied to medical school. So my story starts by sharing I'm a first generation Korean American. My parents moved here in their 20s as childhood sweethearts for the same reason that a lot of folks move to this country, to start a better life for themselves and their future generations in America. Now, that meant growing up, I was always told I could become one of three things when I grow up. I'm sure you can guess what they are. They said, Brian, when you grow up, you can be a doctor, a physician, or an MD. That's the list. Take your pick. And this was really hard for my parents because for as long as I can remember, I wanted to be a filmmaker. I loved swimming in stories growing up, and I remember the first time I told my mom this. I was like, "Amma, when I grow up, I want to be a filmmaker." She heard this and she didn't skip a beat. She was like, Brian, you can always be a Dr. Steven Spielberg. And I was like, only a Korean mom would want their son to be a doctor and a world-class filmmaker and still probably think you're a little bit of a disappointment to the family, but that's okay. I love her so much. She's the one that gave me that bowl cut in the photo that you see up there on the screen. But the truth is, I tell that story as a joke, but there's a much more sinister truth underlying why I never wanted to be a doctor, which is that growing up under immigrant parents in this country was sometimes like having a front row seat to the ways that the American dream can hardly be a dream at all, and sometimes feel more like a hallucination of hope. My older sister, Catherine, who you see up on screen here, grew up with a really serious medical condition. So we would have near weekly visits to the rheumatologist's office, and our rheumatologist's name was Dr. Cooper. Now, Dr. Cooper, I remember, he looked just like Mr. Rogers. Y'all remember like friendly, affable Mr. Rogers on PBS? Looked just like Mr. Rogers and had the most un-Mr. Rogers-like temperament. He was just this cranky, harsh shell of a person. And I remember my family's visits to his office. If you were to sit in on them, it would almost feel like this poorly written comedy skit of all the cultural misunderstandings that you could imagine between him my parents, for whom English was a learned language. So my parents would often leave with new medications they didn't really understand how to give to my sister. And this was well over 30 years ago at this point. So interpreter visits were rare. So I, as a 7-year-old, was often put in the position of interpreting for them. Now, one of the scariest mornings of my life, I remember I was 7 years old. I remember waking up in my bed to the very familiar sounds of my sister's cries just emanating from the bathroom walls. I got up from the bed, I ran out of the room, ran down the hall, turned towards the bathroom, and I saw a very familiar sight. It was Catherine. She was soaking all of her joints in really scalding hot water, and her joints were puffy and stiff and red. And I knew exactly what this meant. She was having another disease flare. So again, we went to Dr. Cooper's office, then again, and then again, and each time, more pills, more confusion, more frustration. And by the third visit, you could tell my parents were getting frustrated and Dr. Cooper was getting frustrated. And as my dad asked me to ask Dr. Cooper what else could be done, I remember Dr. Cooper, he looked at me and he was frustrated. His hair was askew and his face was beet red. He said, "There's nothing else I can do for you. Tell your parents that." So I turned to my parents, and in one of the stranger moments of my life, I told them, "There's nothing else I can do for you." So there's a certain injustice to a healthcare system that doesn't account for a family's cultural beliefs. But there's a whole other level of injustice of having a 7-year-old kid translate a doctor's visit because the system hadn't yet prioritized it to the point that he turns to his confused parents and says to them in one of the most confusing, hopeless moments, "There's nothing else I can do for you." And in that moment, I felt this hot, silvery snake coil up tight around my chest and pounce in my forehead. And it was just my first ever encounter with the sense that something in this world could be deeply unjust. And as that hot, silvery snake coiled inside of me, I decided I want nothing to do with this healthcare system anymore. And that night, as we left Dr. Cooper's office and rolled into our home, the driveway, I remember I tugged at my mom's sleeve and I pulled her and my dad aside. And as sternly as a 7-year-old kid can ever speak to an adult, I told my parents, "Don't ever ask me to be a doctor ever again." Now, in one of the worst spoiler alerts of the century, you all know that I did in fact end up in healthcare. Here I am talking to you now. Story for another time. But the truth is, being in the system now, I still feel that hot silver snake rise up in me. I feel it whenever I hear from a trainee that they were put down inhumanely in a clinical setting by the very people assigned to teach them. Or I feel it whenever I see that certain health professions and social identities tend not to be represented in really critical decision-making spaces. And goodness, do I feel it when I see the health system make my amazing colleagues work more and more and more while humanizing us less and less and less. So it's been a lot of time. I spent a lot of time reflecting on what was happening inside of my 7-year-old body and my family almost 40 years ago now at this point in Dr. Cooper's office. And I think it boils down to a simple paradox. And that paradox is this. We have built a health system that is obsessed with being technically correct, but too often gets it relationally wrong. Technically right, but relationally wrong. I mean, we just saw this during the COVID pandemic, didn't we? We were technically right in unprecedented ways. COVID tests, vaccines, treatments, all developed in historically record speed. And goodness, do we get it relationally wrong, right? We asked communities to trust institutions that had not done the work of becoming trustworthy. We watched racial inequities widen in infections and hospitalizations and vaccinations. And we asked our workforce to absorb waves of trauma and loss and moral distress without building the relational infrastructure to truly support them. So yes, we were technically brilliant, but we were relationally underprepared. So that's why I'm here. I am so passionate about transforming the healthcare system to strive to be both technically and relationally right. And frankly, it's what drives me as a clinician, an educator, and a researcher. And if I'm being honest, it's what quiets that really still aching 7-year-old brother that lives inside of me to this day. Now, if I can be so bold, I imagine that's what brings a lot of you to this space here today, too. Of really underlining that there are people, like real human lives in this healthcare system that each of us work in, and we can't lose sight of that as we work in it. So, of course, I couldn't have named any of this when I was 7 years old as a kid. What I only know now, almost 4 decades later, is that what my family and I were enmeshed in was a healthcare system designed over a power over culture. And I'll explain what that means soon. But that's where I want to turn to next together. So, Paulo Freire, who's a Brazilian educator and philosopher, he spoke about the concept of critical consciousness, that for any of us to be effective change agents, we have to be 100% clear-eyed about the world as it is so that we can most effectively influence it towards the world as it should be. So here's our healthcare system as it is now. Well, we spend over $8 billion a year to try to buy belonging and inclusion in the workplace. And we also spend over $166 billion a year to advance leadership in the workplace. And healthcare is one of the largest sectors that contribute to these costs, which all by the way, 166 billion, that's more than 4 times what the UN has estimated would cost to end world hunger. So I'll just ask the rhetorical question. Is all that investment in DEIB and leadership development delivering the results that we seek in healthcare? Well, the data is clear. We're not. This data tells us that the US has the worst health inequities by far of any country like ours in the world. That despite being about 20% of our country's GDP and billions that we pour into leadership and DEIB, our system continues to generate inequitable outcomes. And I think all of us have seen graphs like this that show that we also have the worst health outcomes, the worst quality of care, the highest healthcare cost of any country like ours in the world too. And this graph tells us that the US healthcare workforce has the worst rates of burnout by far of any profession in the country. So just to orient you all to this slide, healthcare workers are represented in red on this graph. Other essential workers like teachers and social services and farmers are in green, and all other US workers are in blue. And it's comparing pre to post-pandemic. And you'll see that healthcare workers now have significantly higher rates of poor mental health days, intention to leave their jobs, workplace harassment, and burnout. Nearly half of the US healthcare workforce reports feeling burnt out. So just to put it bluntly, we have somehow created a health system that's not working for both patients and our own workforce. Every side of the lever is losing. So I obsess over this question. How can that be? Like, how can we spend billions of dollars on this system, on DEIB, on leadership development, and still be enmeshed in a healthcare system that produces such poor outcomes for both patients and our own workforce? Well, here's my theory, and it's just one. I think that when we see harm in healthcare, Our collective impulse is often to reach for individual level solutions. So just to orient you to the next couple of slides that I'll have up on screen, on the left-hand side is how we get into right relationship with patients and communities, and on the right is our relationship with each other inside of healthcare, our colleagues, our trainees, our workforce. So on the left, on the patient and community side, we often offer things like implicit bias trainings, upstander bystander trainings, cultural humility workshops, all very necessary parts of the solution. And the right-hand side, the workforce side, we offer things like things you've seen before, right? Mindfulness, stress management, resilience trainings, yoga trainings. And I want to be clear, these are good things. Many of them are necessary. I even teach some of them. But what I want to invite us to observe together today is that too often we stop there. And when we stop there, we treat what patients and communities experience and what healthcare workers experience as two separate, disparate problems. But I don't think they're separate. I think they share the same root system. And to me, the shared root is this: an anti-relational system that entrenches power differentials. I often tell students and trainees that rotate with me, if healthcare truly prioritized relationships, I don't think we would have 20-minute clinic visits, but here we are. So power differentials that drive racism and sexism and classism, professional hierarchy, and other forms of false othering. And over time, anti-relational systems, they erase people and they erase relationships in favor of things like productivity, efficiency, and outcomes. And how does it feel to be in a system like this? Well, I often hear the same things from folks. Brian, I feel isolated, excluded, dehumanized, disempowered. And for me, this is where the patient and community side and the workforce side, they meet. Because if you've probably heard this quote by Cornel West, justice is what love looks like in public, then anti-relational systems make love nearly impossible to attain in public institutions, and therefore it makes justice nearly impossible too, for patients and with one another. So that's why I think this is one of the grand challenges that's facing healthcare in the next couple of years. How do we address this relational gap? How do we move beyond individual level fixes and begin changing the power dynamics and changing the relationships that shape the system itself? To me, that is the missing middle. And I get it. If trees aren't your thing, let's try water. Social change organization FSG, they wrote this amazing report a couple of years ago called Waters of Systems Change. And it gives us another way to look at the same idea. They observed all across the country, many systems change efforts focus on shifting individual mental models at the top in order to shift policies and practices and resources at the bottom. And what they observed was the same thing. What often gets skipped is the middle: relationships, connections, power dynamics. And just to give you a quick story, I saw this clearly in 2020. You all will remember murders of George Floyd and Breonna Taylor and other Black community members. And I had the opportunity to support a couple of different organizations, healthcare and otherwise, in their DEIB change efforts. And I observed something really interesting. On paper, many organizations, they were saying the right things. Mission statements changed, policies changed, trainings happened. All of them used the right words. But in practice, a lot of leaders told me that they could feel that something deeper had not changed. So somehow the policies and the mission statements had changed, but the power and the relationships didn't. And I remember checking in with one health system leader about a year after we started working together. And they told me, Brian, we did the trainings, we did the workshops, and nothing has changed. And it's almost like supervisors are still wielding their power like weapons, quote unquote. And that, to me, that is the missing middle that we somehow have to find to repair. So, I'm obsessed with how do we study these thriving communities? And as we've done that, look at what makes communities thrive all across the world, they all seem to share at least one thing. They know how to wrestle with power dynamics. Because let's face it, when the power differentials are as vast of a chasm as that between someone like Dr. Cooper and a 7-year-old kid, yeah, Brian, the anti-relational impacts can feel obvious, of course. But I get it. In the hustle and bustle of our day-to-day work lives, the impacts of power differentials, yeah, they might not be so obvious. it can show up in really subtle ways, right? Like in who speaks and who doesn't, who gets interrupted and who doesn't, whose ideas move forward and whose doesn't. So let's unpack that together just a little bit, because I believe that power is especially important to talk about in healthcare because power is everywhere in healthcare, right? We experience all the false hierarchies of social identities out there in society, of racism, of sexism, of trans and homophobia, and all the professional hierarchies that exist inside our walls, right? The power that instructors might have over trainees, that clinicians may have over patients, that researchers might have over research subjects, and the power that certain professions seem to be perceived to have over others, even though we know that what's best for our patients is when we collaborate across professions. So I think we have to surface and discuss power much more honestly in health systems. And my favorite definition of power comes from Dr. Martin Luther King Jr. You've probably heard of it. And he defined power as the ability to achieve our purpose. The ability to achieve our purpose. And I really like that definition because it reminds me that power is not inherently bad, right? We need power to create change. We need power to build the world that we imagine. And on the other side, we can all experience that power can be used in very different ways. And one other way that we see in the world that power can show up is in a way that can feel hierarchical or more command and control or more transactional. So you don't have to share, but I want you to invite all of you to just bring up in your mind's eye a time in your professional life. Maybe it's work or school or training or volunteering, a time in your public and professional life when you experienced or witnessed power over dynamics. Maybe it happened to someone else. Maybe it happened to you. Just consider, what was the impact of that? How did that feel? You don't have to share it with anyone, but just hold that for a moment. Now, what I can tell you is that when we're in person, I always have folks in the audience share about their experiences with that sort of hierarchical power. And doing trainings on power for over a decade now, literally every room I ask, they can name a moment when they or someone they deeply cared about were harmed by this kind of approach. And that's why this matters. And so one way to really describe this kind of hierarchical command and control approach to power is this term power over. So there's scholars like Dr. Tima Akun, Dr. John A. Powell, the late Kenneth Jones, organizations like the People's Institute for Survival and Beyond and the Othering Belonging Institute. They've all long written about what happens when power over dynamics take over an organization or a culture. And what they found was that power over leadership styles start to perpetuate a set of core values that are inherently hierarchical and transactional. As in, do this for me as much as you can, as fast as you can, and as perfectly as you can, so that you, in return, can stay on this team. And, I think it's important for me to be very clear about something, which is this. Power over isn't inherently bad. In emergencies, in codes, in crises, it can literally save lives, right? Like we need to have power over clear structures, hierarchy, when there's someone who is crash coding in front of us. The point I want to make is the problem that I observe is when it stops being situational and it instead becomes the everyday culture. And that's my core concern. Power over has almost become the default muscle that healthcare knows how to flex. And what we've underdeveloped, what I think we've barely trained, is the muscle of building power with each other. So the work isn't to get rid of one. It's actually to rebalance them, right? Almost as though we have two muscles and one body. And right now, one muscle, power over, is trained almost into hypertrophy, and the other, power with, which I'll talk about in a moment, is drifting towards atrophy. So I just want to invite us to rebalance them. Now, power over cultures tend to reward a number of things, such as putting work over people, individualism over interdependence, perfectionism over growth and learning, and leader-centered growth over collective leadership. And many of us know what this can feel like, right? We perform, We protect ourselves. We stop taking risks. We stop sharing about mistakes we may have made. We stop sharing our emotions, and we bring less of our full humanity into the room. And one of the defining characteristics of a power over system is that a small group of folks with formal power over others have disproportionate access to the majority of resources and decision-making and agency, while so many others around them, they could risk feeling disempowered, dehumanized, and disconnected. Now, why does this matter? This all matters because when we are in this disempowered state, all of us as humans have a tendency to disconnect from our authentic self and instead give rise to something that we call our performative self. The performative self is that version of us, all of us, that scans the room. Oh my gosh, what's safe to say here? What's risky to say here? How much of myself can I really bring into here? How do I need to dress, speak, act, and behave not to thrive, but merely just to survive? Maybe you felt this before during a job interview. Maybe you felt it during the first week of a new job, or really, maybe you felt it in any room where the power, it feels really, really unbalanced. And what I'll share with you is there's a very real human cost to this. That when whole teams operate from that performative place rather than the authentic place, we cannot be as creative, as honest, as trusting, or as courageous as today's healthcare system needs us to be. And I promise, I'm not just pulling this out of thin air. There's mounting evidence demonstrating what power over environments can do to teams. And here's just a couple of my favorites. The first is there's the work of someone whose name is Dr. Keltner. He's a psychologist at UC Berkeley. And he discovered something called the power paradox. And the power paradox is this. People seem to gain formal power through traits that are inherently relational, through things like empathy and open communication and collaboration. But here's what's interesting. Once they ascend into a position of formal power, somehow these traits tend to fade. The ability to empathize decreases, and the number of collaborations, they literally decrease too. That work was further supported by someone whose name is Dr. Sukhvinder Obi. He's a neuroscientist at McMaster University in Canada. He conducted brain MRI studies, and he found that the more one ascends into formal power, the less the areas of the brain that signal empathy pathways light up. They literally start to dim. And then on a healthcare and interprofessional team level, there's the work of a midwife named Dr. Emma Kearns. She and her team did these literature reviews that found that as power over dynamics increased on an interprofessional health team, patient safety worsened, team effectiveness plummeted, and communication and psychological safety decreased significantly. So in short, when we focus too much on being right and not getting our relationships right, things fall apart. Now, again, I want to be clear about something. All of this research, it does not mean that leaders with formal power are less compassionate or that they're worse communicators. The research does not say that. It's very important for me to be clear about that. What the research does say is that there seems to be something very intoxicating about power, that all of our human brains have this physiologic tendency to succumb to it. And I think we can all think of incredible leaders who are just exemplars of compassion and empathy and good communication. What I would argue is that what these exemplar leaders have done is develop a self-awareness to this tendency, that they can see power dynamics entering and shifting a space, their self-awareness kicks in, and they somehow choose to show up in a different way. And that's what I'm inviting us to do with this information, right? How do we refine a self-awareness? Because self-awareness unlocks choice. So when power is showing up in our space as a leader or a team member, we can know to ask ourselves, can I show up differently in this moment? So that's power over. And I often wonder, why does it have to be a rite of passage for all of us to somehow be impacted, if not harmed, by power over dynamics, simply just to exist in this healthcare system? I believe that power can and should be used in another way, and that other way might be power with. Power with is building power collectively and in community with each other. This is the power that we see in, let's say, social movements or in beloved communities, or in the power of collectives arm's length. But it doesn't always have to be that grandiose either. Power with can exist in these simple moments that have profound impact, right? Think of the times when you felt truly seen or heard or valued on a team. Or think of the moments when a leader pulled you aside to ask for your input on something that really mattered and acted on it. Or think about a moment that the team paused the agenda to set it aside to check in on how you're doing after you shared about a really tough life event. Power with exists in those moments. That is what power with can feel like, of choosing connection over control. Not sentimentality, but courage. And this kind of power might feel like putting people at the center, not just work. And it might look like creating braver spaces where people can bring more of themselves into the room. It might look like flattening hierarchies so that decisions reflect the wisdom of the entire team, not just the person with the most formal authority. It might look like treating mistakes not as proof of failure, but as necessary steps towards growth and learning. And it might look like leaders measuring success not by how many followers they build, but by how many other leaders they help grow and develop, that we lift others as we climb, that we build as we all collectively grow. And you'll remember that in power over systems, people often feel pressured to bring a performative self to work, guarded and careful and risk averse, scanning the room for what's safe to say, what's not safe to say. Power with cultures, they invite something very different. They create the conditions for people to bring more of what we call our authentic expressions, our creativity, our courage, our honesty, our imagination, our care. And that matters because what healthcare does not need more of in this moment are people merely aiming to survive in the system, right? We need people with enough trust, enough safety, and enough agency to try to boldly reimagine it. And that's why power with culture, it's not sentimental, it's strategic. It is what helps teams move from guarded to created, from isolated to connected, and from risk averse to bold. You might have heard the saying, have you ever heard like, oh, we only use 10% of our brains, right? Like we don't use all of it, which by the way, a dear friend of mine who's a neurologist was like, Brian, that's not true. Stop saying that in front of an audience because it's not true. But just roll with me here. You know how they say that we only use 10% of our brains? It's almost like power over. It's like we've only unlocked 10% of our team, right? Their potential, their creativity, their abundance. And what I'm inviting you to do is with power with, we may unlock a lot more of our team. So in organizational behavior lingo, this is the movement from hierarchical and transactional leadership and towards embracing relational, communal, and collective leadership. And I promise, I'm not pulling this out of thin air either. There's decades of evidence that support relationship-based leadership models. Here's just two of my recent favorites. So this one is a recent systematic review by a mentor of mine, Dr. Jody Hoffer-Gattel, who's over at Brandeis University. And she and her team created a model called relational coordination, which is a key predecessor to relational leadership. And she has done this work for long enough now that she can look back and do systematic lit reviews. And when she dug into healthcare, she found that relational approaches, they were associated with improved patient care, including post-surgical outcomes and patient quality of care, improved costs of care, including lower inpatient length of stays, lower outpatient costs, and improved employee satisfaction and better turnover. So in short, better care, better costs, and better culture. And this next one is one of my favorite studies from the last couple of years. It's a cross-sectional analysis that was done by Relate Labs co-director of research, Dr. Sam Edwards here at OHSU. He and his team looked at survey data from over 700 outpatient practices all across the country, trying to better understand what leadership characteristics differentiated from high burnout clinics from what his team labeled zero burnout clinics. I was like, Sam, seriously, there's clinics with zero burnout. He's like, yeah, Brian, they're not a lot out there, but there are, and we want to learn from them. What they found was that in those zero burnout clinics, leadership models built a relational infrastructure, so an intentional way for colleagues to get to know each other in and out of work and who they are outside as people in the world. They obsessed over cultivating and sustaining psychological safety, the sense that the team is safe for interpersonal risk taking. And they also worked really, really hard to minimize the impacts of power imbalances. In short, they really trained that power with muscles. So again, you'll remember 2 muscles, 1 body. The clinics that thrived, they flexed both muscles. So much of the work that I do is trying to be clear-eyed about the world as it is, as bleak as that might be, and bridging that to being firm in our true north of trying to create the world as it should be. And showing the way to that true north, that's the central focus of the work that we do at Relate Lab. Relate Lab is built on a very simple premise, which is this. How do we build relationships and community inside of healthcare that shapes how we build community outside of it with patients, patient leaders, communities, community leaders, community-based organizations? In other words, we believe that if we don't transform how we relate to each other within our teams, we shouldn't expect trust, connection, or equity beyond them. One of my favorite quotes is by someone named Angel Kyoto Williams, who says, "Without inner change, there is no outer change. And without collective change, no change matters." So we want to be on that continuum of working on inner change, working on outer change, and working on collective change as well. And here's how we aim to do it. Like, how do we move from theory to practice? So we believe that the world as it is that we have a transactional healthcare system that is just riddled with hierarchy, silos, and fragmentation. And what that does is it undermines human connection, shared purpose, and trust. And what that does is it leads to a lack of connection and psychological safety. We are often seeing that relational practice are not seen as being essential. They're kind of called soft skills, even though there's evidence that shows the dramatic impacts of these relational practices. And that we operate in what feels like a bottom line focused culture. Profits over people, margins over mission. And the outcomes of that, as we heard earlier, is that every side of this house loses. There's deep burnout in the healthcare worker workforce, and there's poor outcomes with patients and community. What we are trying to do is acknowledge that we need a two-sided model of systems change. It's not going to take healthcare workers only to change the system, and it's not going to take patients and communities only to change the system. It's going to take all of us together because healthcare is that complex. And we have 2 separate programs. One is called the Relational Leadership Institute, or RLI. We'll tell you more about that in a second. And the other is called Health Equity and Leadership, or HEAL. We'll tell you about that in a second too. Both programs are made of the same 6 core relational practices DNA. And those 6 are this. One is that we cultivate belonging and psychological safety. We help share power and decision-making. We help people to co-create relational norms. We center storytelling and move from deficits-based seeing to strengths-based seeing. We bridge across differences in this deeply polarized world, and we help address conflict and repair meaningful rupture. And by doing so, what we hope to inch this healthcare system a little closer to is a healthcare system that feels more relational, that relationships and belonging shape how we work and co-create solutions together. And by doing that, we see these bright spots where relational practices, they're learned, they're applied, and then they're sustained. That strong relational cultures, people feel a sense all of a sudden of belonging, of being included, and feeling agentic, having agency. And that we can build these core teams of bright spots that catalyze systems change within healthcare. And by doing that, what we hope is that every person, clinicians, staff, trainees, patients, families, community leaders, they can feel valued and connected in a healthcare system that feels relational and loving to them. That's our theory of change. Now, you might hear that and say, Brian, that all sounds good. Cool, fancy slide there. What are the impacts? Show us what's happened. So that's what we want to focus on in this kind of closing section here. So the first program is the Relational Leadership Institute, which supports the healthcare community. And our flagship program is RLI, which really tells people how to practice relational leadership, which is a human-centered approach to leadership. It supports folks who go through it to really unlearn these hierarchical and transactional ways of being and to embrace and relearn power with. And we do that through promoting relationships, psychological safety, and belonging. And we provide these 4 foundational skills that all of our participants learn how to foster: authenticity, belonging, interdependence, that we're all not just connected, but that we depend on each other, and a growth mindset as well, that none of us are finished products. And a couple of impacts here. RLI seems to foster useful and timely leadership skills. We have been in existence since 2017, so we're coming up in our 9th year anniversary. We're just about to wrap up our 17th cohort. I have had over 500 people at OHSU go through the full 3-month experience, I think nearing tens of thousands who have gone through some sort of workshop or training here in Oregon. We have 90% of RLI participants who report that they have developed skills through this program that will help them in their work. And here's what's interesting: over 80% report using skills at least 6 months after a course completion. So there's something that's sticky about these skills. It really stays with people. RLI also seems to significantly improve well-being. What you see here is that from pre to post, we have statistical significance in improvements in a validated measure of well-being called the Well-Being Index, or WBI. And here's what's fascinating: these improvements sustain, again, 6 months post-program. So these well-being influences, they seem to shift people, and it's sticky even after the program ends. We see the exact same pattern for belonging. We use a validated measure of belonging called the psychological sense of community. Again, pre to post program, statistical significant improvement in a sense of belonging. And again, somehow they leave the doors, they leave the program, they're done 6 months out, and that sense of belonging sustains itself. So there's something sticky about all this. Now, don't take it from me, like don't make it about p-values. Here's a couple of things that folks have shared with us. One participant said, power and equity surfaced for me personally through how to actually work away from harmful systems of power that many people are familiar with, but don't know what to define as an alternative. Just another one: as a new manager of a new program at OHSU, I can't imagine having started my team without knowing this information. Seeing the leadership model by facilitators was instrumental in forming my awareness of how it could look for my team. And ever since we've done this program, we've been able to expand to the University of North Carolina, University of Utah, OCHIN, the Cambia Health Network, the California Network. The reason I included this photo is that the person who brought RLI from OHSU to UNC is at the middle of the screen. She's wearing a colorful scarf named Dr. Sarah Smithson. She unexpectedly passed about 1 month ago. And so I've been really thinking a lot about how do we honor her legacy in creating loving and relational systems. So in this moment, I just want to pause and really honor Dr. Sarah Smithson's work in bringing the things that we've done here at OHSU to a new family, a new community at University of North Carolina, Chapel Hill. Next, I want to pivot to our community-based work, which is Health, Equity, and Leadership, or HEAL. And what we do is we integrate community organizing into healthcare so that folks who are most impacted by inequitable systems lead the change that they want to see. And you see our model here. We start with listening. We build a community core team that really centers community voice, and it's rooted in trust and psychological safety and love. And we equip our leaders with relational leadership skills. And what we've learned ever since we created this program, 2014-15, is that these efforts start to point in either one of 2 directions: either systems change, change in the healthcare system with an equity lens, or advocacy of policy change that centers community voice. And here's what we've worked on over the last couple of years. Our very first campaign, we worked on affordable housing, and we passed a tax set-aside called tax increment financing that increased affordable housing dollars in Portland by an additional $67 million. We, in 2017 to 19, passed, with the help of amazing School of Nursing faculty and community leaders, a language access policy that mandates that medication labels be translated to non-English languages. And the one that we have in Oregon is the most inclusive bill of its kind in the entire country. And many more states have now adopted this law as well. Now, in 2020, you'll remember something big happened, the COVID-19 pandemic, which made bringing people together a lot harder. So instead, what we did was we did a social connection project where about 150 community members who were identified as being high risk for social isolation or loneliness They were connected with the same volunteer for about a year and a half to 2 years, who provided 2 to 3 weekly calls to talk with them for 30 to 60 minutes about how they're doing, getting to know them, building a relationship. In about 2020 and 21, we became very lucky. We found funding to hire a health equity community organizer whose name is Hillary Nichols. She's amazing. And she started doing listening sessions and found that we have a lot of folks who have lived experience of justice or criminal justice involvement. And through that campaign, in a couple of months, we are just about to hire a peer support slash community health worker, someone who has lived expertise of justice involvement. And once they get hired, we will formally launch the first ever medical home for folks returning home from carceral settings. And the entire clinic has been, the vision for it has been truly created for and by people who have lived expertise. And you see many of them up on screen here. So again, this is not our idea. Hillary and I had no connection to the justice system and have kind of accidentally become quasi experts through getting to be in relationship with so many people who have this lived experience. I'll be very quick here. We also ran a civic leadership program for folks, Latinx individuals on the West Side, and they launched a 200-person assembly called the Foro de Salud Justa, or the Health Justice Forum. And many legislators come, many community members were able to speak to them about the changes they wanted to see. In 2023, we launched Community Health and Racial Justice, which aims to reduce racial inequities in diabetes care in East Portland. And the community patient leaders, folks of color who live with diabetes, said we should launch community-led diabetes groups. And we just are about to wrap up our first cohort where we co-facilitate a clinician and a community leader who brings together patients of color who live with diabetes, and both professional and lived experience come together as one, and community is built. We've been able to expand this model to Washington State, to Montana, and one of our multimedia storytellers at Relate Lab created a 12-minute documentary and just won the Oregon Documentary Film Festival. This is Elaine Uchison. So she won the Best Director Award a couple of months ago. So huge thanks to Elaine for elevating our work in kind of these dissemination practices that align more with what we like. So, all right, let's get to some closing reflections here. If you're hearing this and you're feeling, gosh, yeah, I'm on board about the impacts of power with culture on teams, you might be wondering, like, what can I do today to start doing this? So I want to offer just a few evidence-based thoughts. And I'm just starting small here. I think many of you all on this call probably do a lot of these things. But we found that building in check-in and check-out processes, so check-ins where we can just ground into being in this moment together, and check-outs where we can intentionally evaluate meetings together, are helpful. We always co-create how we want to be together through something called community agreements or norms, and we get very intentional about what those behaviors look like so that we know how we can support one another. A dear friend and mentor of mine, Kazu Haga, talks about how in all organizations, decision-making, information flow, feedback systems have implicit processes, and if you don't make them explicit, power over culture takes over. So make power and decisions transparent. At Relate Lab, we have actually documents that really show how do we make decisions? How does information flow in our organization? What are feedback systems so that we can learn and grow together? Repair ruptures early, engage in meaningful conflict. We live in a very conflict-averse environment. I certainly grew up in a family like that, but I've really learned the importance that conflict is the relationship trying to heal itself. And then acknowledge what people are carrying. These are very hard sociopolitical times, and we're all bringing our full lives into work, and creating just a little bit of space for all of us to get to see one another in those ways can be deeply profound, deeply transformational. So I want to just give you all maybe just like 20 seconds, like bring up in your mind's eye one team that's really important to you, and spend just 20 seconds here writing down 1 to 2 actions that you want to try. Maybe there are ideas I gave, maybe there's something else that can help narrow power distances and build deeper community on that team. So I'll just pause here for a few seconds. You won't have to share it with anyone. It's just a commitment to yourself. But let me give you just a little bit of time as I sip some water. All right. Thank you for doing that. One last closing reflection. I promise. I'm almost done hogging the mic. I know I just asked you to write down one thing, so I think it's only fair if I close by naming my one thing. And I'll just say the quiet part out loud, which is these are really hard times, aren't they? Like our healthcare workforce is exhausted and stretched thin and burnt out. Communities in Oregon are watching equity gains that took decades to gain roll back. And immigrant families are being pushed further to the margins through the oppression and violence of ICE and our administration. And oh my goodness, I think about this, that around the world, we witness this relentless violence, right? In Iran, in the Middle East, in Ukraine, in Sudan. It just keeps going. And in unprecedented times like this, the fractures, they show up everywhere, right? They show up inside our teams. They show up outside in the communities that we live in, that we serve. So I get it. Like everything I just talked about, I'm not pretending that it's easy. Like I am not so awash in the waters of relational leadership that I don't see what's happening right now. I know that when I ask you to write something down, for even to do one thing that we wrote down, I know it's a path that requires us to swim against the current every day. And I know that takes courage. I know it's going to ask you to do some boldness too. So what gives me hope? It's this concept that I'm going to show you on screen. It's by James Baldwin. Ever since January 2025, I read this quote to start my week because I need it, because it grounds me. And it's this: love has never been a popular movement, and no one's ever wanted really to be free. The world is held together, really, it is held together by the love and the passion of a very few people. Otherwise, of course, you can despair. Walk down the street of any city, any afternoon, and look around you. What you've got to remember is what you're looking at is also you. Everyone you're looking at is also you. You could be that person. You could be that monster. You could be that cop. And you have to decide in yourself not to be. Love has never been a popular movement, and it's certainly not right now, because I don't know about you, but I am tired. I am exhausted, and I'm grieving constantly. But here's the reality. In these challenging times, we have to choose for ourselves. I can't decide for you. No one else can decide for you of becoming that monster or deciding not to. It's up to us, each of us. So I hope we choose justice. I hope we choose each other. And in the face that all of us are up against, I hope that we choose love. Because it's what I needed when I was that 7-year-old boy with my sister. It's needed now in our professionalized spaces. And oh my goodness, is it needed in this greater socio-political reality that we're living through right now. That we need to hold one another in this shared human project that is wondrously simply about being alive. So love has never been a popular movement, but I choose it. And that's my one thing I commit to. And I hope you join me. Thank you.
Thank you, Dr. Park. Such a amazing talk. Always great to hear from you, and I'm just left with so many things in my head right now to think about. This last piece about love, I'm really drawn to that concept, and I've heard you talk about this before. And I just wonder if you would maybe you could share with us maybe some really concrete examples of how you live that you offered us that sort of challenge to let love in. How would we see that show up, and how in you as a way that maybe we could begin to emulate?
Yeah, absolutely. My answer has changed a lot over the years. There's a concept that many activists spoke of. It came from a Greek word called agape. It's a very specific kind of love. There is a love that we all live with our beloved chosen family, perhaps our lineage family. But there's a love that we all extend to one another that underlines the fact that all of us living on this planet are interdependent on one another and on all living things. And so, I'm from Minnesota, which Dr. Coleman knows, and I feel deeply connected to it. I've always wanted to not be a Minnesotan. I left the first moment I could. I'd never really try to go back, but I have never been prouder to be a Minnesotan than January 2026 when I witnessed what happened with the ICE deportations and Renee Good and the sense of deep solidarity. I raise this example just to say what I witnessed in January into February and March of 2026 was agape, that love. This love that we have in a neighborly way for one another. Because it's easy when we say love for all of us. You notice in your bodies, like, is there just a feeling of just like, oh, but that's a soft kind of thing, or it's kind of reserved to personal life. But I'm talking about the way that love can express in public ways. And I will just share with you all about 3 years ago, my commitment to my work life was kind of careening off the rails, and I was not showing up in my family life the ways that I wanted to. And I decided in that moment that the most important thing I will do in my life is just try to be a better ancestor to this world. We are all ancestors right now to a healthcare system, whether you want to be or not. You are an ancestor to this healthcare system for my child and his friends and his children. And I want to invite all of us to think, what's my little thing that I can do to be a better ancestor to this healthcare system? And if you want to, extend it to the world too. So I think, that's the deepest expression of agape or love that we can offer. How do I be a better ancestor? Indigenous communities have taught me about 7 generations. Let's live in a way that 7 generations from now the world is better. I think that's our invitation. How do we express love for one another, even those we haven't met, in ways that leave this world better 7 generations from now?
It's fantastic. I appreciate that. There's a lot of really just great comments and lots of appreciations in the chat here. I might just read one here in the last couple of minutes that we've got. The comment is, I really love the work being done in this community and the thoughtfulness behind this approach. I'm currently pursuing a second doctorate in whole health leadership, and honestly, so much of what is being presented here is exactly the kind of systems and cultural transformation work we are discussing in the program. It is really encouraging to see people actively trying to shift healthcare toward more relational, human-centered, and psychologically safe environments. Yeah, it is very encouraging. We have about 2 minutes left. I would say and mostly just a lot of appreciations here. Dave Hoyt adds a different Baldwin. The children are always ours, every single one of them, all over the globe. And I'm beginning to suspect that whoever is incapable of recognizing this may be incapable of morality. Yes, it's a great quote. All right. Any last thought you'd like to share with us?
Yeah, I know it can feel extremely overwhelming to know how to change a healthcare system that has been operating as it has for this long, especially in times like these. And I won't pretend to know what any of us can do as individuals, but I do think that in this moment, now more than ever, what we need is we need to find one another. John A. Powell, who I referenced in this talk earlier, recently posed the question, can organized people ever defeat organized money? And there's kind of a quote like, no, never. And he observed an important nuance, which is poorly organized people can never defeat organized money, but well-organized people always can. And organizing is always just about relationships. So what I invite us to do is the only thing that has ever been able to upend these very hierarchical, oppressive forces has been the power of organizing ourselves well, not reperpetuating the same tools of non-transparency and selfishness, othering and shame that exists in so many spaces. So I invite us all to be a little bit more open in deeply polarized times to how can we bring new bridges and build coalitions that extend a little further than they typically have so that we can organize one another well.
Wonderful. Thank you so much. Can't thank you enough for joining us today. It was really an amazing talk. I want to remind everyone that Dr. Park's talk will be recorded and posted on the OBHC website. For those who want to see it again or who have colleagues who may benefit from seeing it, please share. Our next and final OBHC presentation for the year is on Friday, June 12th at noon, when we're going to hear from Dr. Daniel Kim, PhD, MPH of the Albany Medical College. He'll be speaking on a topic that is yet to be determined, but I do hope that you'll join us in closing out this OBHC season. Thank you again, Dr. Park. Appreciate you. Have a nice
Thank
day,
you.
everyone.
Bye.